Welcome. This is a conversation between Whole Washington, myself, Thomas Kennedy, and PNHP with Dr. Paul. Always wonderful to talk to you. Paul and I have talked a little bit before this, kind of collaborating about how we can work together. And we've created a list of things to go through that are really important issues, both nationally and at the Washington state level. So let's start with Medicaid deprivatization.
Yeah. So earlier this year, as you probably know, PNHP released a report showing that privatized Medicaid is really hurting almost every state in the country. There are only two that are deprivatized, and the most notable one is Connecticut. There's other states that are kind of have gone back and forth between forms of deprivatized and going back to privatization, and some that are leaning into privatizing more recently, and we're already seeing the effects of privatizing those states. That state is particularly North Carolina. But back to Connecticut, what we see is that prior to 2011, the state of Connecticut was a particularly privatized state. And around that time, the state transitioned into where they're going to remove these for-profit middlemen that are usually Aetna, Humana, the big insurance companies, and they're going to allow the state to just be the ones to coordinate the care. So really, all these companies are doing is coordinating care as they should, not that well, denying care, which is what they're really put in place to. And by denying care, they're managing costs, but really what they're doing is denying access. Their motive to do all this is obviously profit motive. They made, millions, if not billions of dollars annually. So by returning these powers to the state, we saw in the report that in the state of Connecticut, doctors returned, patients reported better outcomes and better satisfaction with the program. And we saw an overall safety in terms of ER visits and a reduction in ER visits, but a safety and in terms of mortality decrease in the state. So we know that with preventable care, people can live, fuller and healthier lives through a simple thing like removing profit motives and private insurers.
Yeah, and we saw the same thing. We loved the PNHP report, and we have already been tracking what has happened in Connecticut, where our approximation is like a 7% decrease in costs, switching we call them in Washington managed care organizations from like a separate company that is contracted out to instead paying them just for the administration, which is what Connecticut does. Like, finding a group to administer, but not giving them choices over what is denied or what is not denied. And that leads to 7% decrease in costs, 7% increase in utilization. And that increase in utilization is weighted towards more preventative care, less emergency room care. And that's really, really encouraging. And it's very frustrating that we have allowed these managed care organizations, or whatever they're called across the different states, to continue to thrive. In Washington, our managed care organizations are Molina, which is a multi-state, Coordinated Care Corporation, another one, United Healthcare, obviously a wonderful one, and WellPoint Washington. These are our national groups. And then we have Community Health Plan of Washington, which is a actual nonprofit managed care organization here within the state. They're actually a member of our Healthcare as a Human Right Coalition. And what we learned actually very recently was they pay back their profits that they make to our community health centers. So there's a weird cyclical nature to how money is spent. Even though all of this is healthcare for economically disadvantaged people. It's a weird way to do things, and there is no reason it should be this way.
What's really sad is that these plans are particularly for not healthier people. And what I point out is that when you get very sick, to the point that your care is actually costing these entities the profitability margins, they try to push you off. And every state, you can't push someone off of Medicaid onto nothing. So every state must run their own basically version of self-managed Medicaid that does not care for, the majority of people who are well, but are still need, obviously, Medicaid coverage. And so we know that states are capable of doing this. They currently are doing this. Every state has these registries and plans, but they are not offering it to the majority of people. And we know that this care, like I said, is superior. So basically, if it's about 10% of the population or such is on one of these kind of more state-run Medicaid plans, push out the private insurers and have it completely run by the state is our proposition. And the other thing I'll add is that annually about $40 billion is lost between all of the states that could be put into care and is instead being turned into administrative costs and profit. And this is coming at a time when $80 billion is being sucked out of the Medicaid fund because of the work requirements. Really reinvigorate the Medicaid program and balance some of the spreadsheets where states are picking up the costs for economically disadvantaged people.
Yeah, and one of the things that we would look forward to with this savings realized through Medicaid deprivatization is expanding the pool from 138% upwards to maybe 200, maybe 300% of the federal poverty line, just because one of the worst served groups medically of human beings in the country right now is the group between like 138% and 200% of the federal poverty line, because they can't afford private insurance, but they can't qualify for Medicaid.
Absolutely.
Yeah.
And so, while this isn't a long-term answer, it's not the most efficient answer. It is exactly what you said. It's a stopgap measure, basically, that PNHP would support. I'm glad that whole Washington supports. The goal is to expand this care, even higher, and to cover everyone for the full breadth of care that they need. But we'll take any and all steps forward that we can in the meantime.
Yeah, and I should shout out that whole Washington this year is introducing legislation. We don't quite have bill numbers yet, but very, very soon for Medicaid deprivatization at our state level. And it's based on the work of actually PNHP's own Dr. Steve Temple from Hawaii, who wrote something for Hawaii, and then we have adapted it for Washington and then sent that to our legislative writers, and they were going to write a more Washington version of that. So
lovely.
Yeah. Awesome collaboration between our orgs. The nightmare that is being realized like literally right now, which is
real time. Yeah.
Premium tax credits not being extended, the ACA premium tax credits. In a lot of cases, this is leading towards people's insurance going from $300 to $1,200 a month, from $600 to $1,400. I've received many stories from our community here in Washington State of these, because Washington State, frankly, did one of the best jobs expanding the Medicaid expansion through the ACA. We went from above 14% uninsured to below 4%, which is pretty awesome. But it also means we're the most at risk when the ACA gets cut. And that's what we're seeing now.
There's the ACA that initially established the expansion of Medicaid it did expand Medicaid, but it also expanded, it created a healthcare marketplace that we are seeing where people can go and buy standardized plans, but then from private insurers for a set fee, and that they're not going to have prejudice against them for prior, conditions. And then how did that lead up into 2020? Take us from there.
Honestly, my knowledge of the history is a little fragmented. Okay. My understanding of these premium ACA tax credits is they're actually COVID era.
Yes, exactly.
Yeah, so I forget it. I think it was 2020 when these were put in to kind of lessen the burden that citizens in the 300 to like 460% of the federal poverty line or something along those lines. In the meantime, because we have pumped so much government money into these private plans for people in this range in between where Medicaid is and where private insurers kind of take over, but this in-between gap, there's been a huge inflation in the cost of insurance premiums and the rise in deductibles and worse coverage and all that kind of stuff that goes along with that in that range because the government's been subsidizing it. And now that the government is no longer subsidizing it, these people are going from what may have been a $500 a month bill back in 2019 to now being a $1,400 bill, both through the normal inflation, through the subsidization and the profitability coming in from the insurance companies, and through the general increase in healthcare prices that has been out of control. And it's hard not to see just like a self-defeating circle of more people getting kicked off because of the increased prices of insurance. That's one of the scariest things of the premium tax credits increases. I think a ton of those people are going to decide, I got to pay for rent, I got to pay for food, I can't pay $1,300 a month for health insurance. We're going to see fewer of those people on insurance, which means pools are going to shrink, which means more people are going to be going to the emergency room without insurance, and everybody else is going to have to pay more because the hospitals are still going to cover those people who come into the emergency room. They're still going to take care of them because that's what they do. And they're just going to pass the bill along. And then the insurance are going to raise the rates, and then more people are going to get kicked off. And then we see it repeat.
Absolutely. So these ACA subsidies were created to help working class people, like you said, that were not given great access to affordable insurance. And it really lowered the bar for them and helped subsidize some of the costs that they were bearing to acquire still private insurance, but still, so they still do the creepy things that private insurers do, but at a much reduced fee. And these are extremely expensive plans for the government to pay because they're subsidizing all this, but they were necessary to help people get insurance. And what we saw just prior to the implementation of this bill, prior to COVID, was that uninsurance was increasing. And so after the implementation of this bill, we saw that decrease to historically low levels, similar to that of just after Obamacare was introduced, when things were affordable somewhat. And so as people, it was never really that affordable, let's be honest. And so as people fall off these plans, the pool is going to shrink. And so just the very sick will end up in them potentially, those that know that they need this to survive. And that will make the cost inflate and balloon even more. So we're, like you said, we're in a death spiral at this point in terms of these ACA plans to a large extent. And that will make our hospital systems less stable, where they have more people showing up with uninsurance, and they have to, specifically in rural places that don't have quite as many insured folks. And so these hospitals will have a more difficult time floating, making the numbers work and staying afloat. In terms of these folks and the care that they're going to receive, it's going to be awful for outcomes. And we're going to see mortality increase, not just from ACA, but also from Medicaid in the coming year, as people lose access to care and uninsurance rises like we've never seen before. And it's all unnecessary. We know that we have better answers. We know that these are not the tools that we need to actually prevent death and harm to folks in this country. But they, again, are stopgap measures for people that are, working class families that deserve care just like you and me.
I know it's kind of a hopeless situation. It feels like there's no agency.
I know. No, and why are they doing this? I think the last thing is I would add that the Republicans are totally, stonewalling any movement on this discussion. Speaker Mike Johnson sending everyone home without discussing putting this to the floor, because they have decided to instead give billions of dollars to the healthcare of working class families, give that money to billionaires, and spread the money around there in terms of tax benefits. And they need to balance the books in their mind. I'm all for balancing the books, but not for billionaires profit at the expense of working class families' healthcare. That's just a no.
Yeah, and I just want to throw out there that our books aren't balanced. So
There you go.
federally, we're spending like 40% more than we're pulling in. So if you're calling that a balanced book, then you and I have a disagreement. Back in 2021, the Universal Healthcare Commission was put into being in Washington State. This was really spearheaded by one of our coalition members, Healthcare for All Washington. The entire purpose of this is to investigate how to make universal healthcare a reality in Washington State. Now, there's some frustrating parts of this because it was written without really specific requirements from the commission beyond reporting to the legislature once a year. So what has that led the commission to do is that they kind of focus on the low-hanging fruit, the really easy to do stuff, because they have no obligation to actually do anything. Instead, what they have an obligation to do is to find inefficiencies or really easy fixes they can do without needing legislation, without needing big substantive change. What I like to call them is kind of like an ACA expansion commission, because they have done that. They have helped our healthcare authority here in Washington State supply healthcare to more people and really drop our uninsured rate. They have been very successful in that. Unfortunately, what they have not been very successful at is actually doing anything about implementing universal health care. But at Whole Washington, for the reason that our Universal Healthcare Commission just really isn't moving fast enough, we've done a few things. First, we've really increased the turnout, providing public comment to our Universal Healthcare Commission to try to push these folks on the commission towards making substantive change, to change the voices that they're hearing from. And then the second thing we've really worked on doing is we have written a Universal Healthcare Commission deadlines and deliverables bill, which will make them have to function like, as Paul's about to talk about, the Universal Health Plan Governance Board in Oregon, and actually have to present a unified plan to the legislature, which, if the legislature doesn't pass, will then go to the ballot and create a system where we could have universal health care in our near future.
Well, I think you already know more than I do, but I think we still have the eyes on the same prize. I know that here in Oregon, we have a, like you said, collective governance board who is attempting and has a deadline to create a proposal for how to move to a universal system. There are a lot of hurdles. This would obviously only be for the state of Oregon, but one of the big hurdles is that we need to get approval for these Medicaid waivers. And so what the waivers are is usually like in any time you want to do an experiment, like ideally with a positive change to see if it improves health and outcomes, you submit a waiver to CMS, and CMS has to approve that. This is kind of similar to the work requirements that were put in place by Georgia, Michigan, and Arkansas, which were all awful. But ours was one that would actually improve care. So the Medicaid waivers, but then also we would need to fold in like the private entities and figure out some way to phase them out in Oregon as well, and how to incorporate the Medicare money as well. Right now, we're at the very early stages of that, and I actually don't know. I know that they're taking petitions and trying to hear from citizens about their opinions, and we have a board that is at least a group of experts, is my understanding.
Yeah, so a few things about that. First, the waivers are important, and to become a single-payer universal healthcare system, you need Medicare and Medicaid waivers. Right. You need essentially Ro Khanna's state-based Universal Healthcare Act, which is the national legislation to streamline states' ability to create universal healthcare systems. In other words, to streamline getting those waivers and getting CMS and HHS and all the other relevant national organizations to play ball with the states and actually pay money into the system. But you don't need those to have universal healthcare. You can have multi-payer universal healthcare. This is a really actually common system throughout the world. Single payer is actually rarer than multi-payer is. And so we could do multi-payer at the state level. Is it less efficient? Absolutely.
Yeah.
It's absolutely better to have Medicare and Medicaid paying into, in our case, the Washington Health Trust, this big ball of money, and then that ball of money pays all the bills. And nobody else is paying any of the bills. as it stands, without the waivers, what would happen is if like a 67-year-old person goes to the hospital, they're on Medicare, Medicare would pay some bill, and then the Washington Health Trust would pay a little bit more. It would be kind of a pain to have a system that works like that for the providers comparatively. However, even that system that is multi-payer and more complicated is still so much simpler than our current system, where there are literally thousands of different insurance plans that hospital administrators have to juggle and get on the phone and talk to people and figure out. And everybody from doctors down to nurses, down to physicians assistants, that everybody is wasting so much time not providing care to actual people who need it, and instead talking to some agency on the phone that doesn't need to exist.
Absolutely. And it comes down to the question of, do you want your money spent on care, or do you want your money spent on administrative costs, CEO pay, and Wall Street dividends, basically? And so by removing the private insurers, we are removing profitability, which is amazing. Healthcare should not be for profit. And we're also moving those administrative inefficiencies, those denials, So with this money, we can dump it back into care that is not being covered, such as long-term care. What do you do when someone's sick and they can't just go to a nursing home for 30 days? They don't have family. They need to stay the rest of their life in some type of long-term care. And for people that do not have Social Security checks, a lot of long-term care facilities will not accept them. How it works is care facilities sometimes will accept them, but they need to be paid. And how does that form come in for someone that's in retirement age? Their Social Security benefits. So it's really a shame that we put the burden of being in a long-term care facility on the individual or on the family. It's incredibly expensive and really returns that care to the household, which is not right. We should collectively as a society be lifting ourselves up together. Removing these private entities will remove the inefficiencies that we spoke of and the profitability that is just so unnecessary in a field that is based on a human right, caring for each other.
Yes, and just to bring things back, I really think Washington and Oregon are trailblazers on this whole Universal Healthcare Commission.
I would add New York and maybe California.
Yes,
yeah.
Absolutely. California was super far ahead a little bit ago, but they've had a rough couple of years in terms of the Universal Healthcare movement. The current governor, despite his presidential ambitions, is absolutely dreadful on this front. Gavin Newsom is an enemy of universal healthcare. Really exciting stuff happening, especially Oregon's Universal Health Plan Governance Board. Really recommend checking out if you want to learn more about what's actually happening surrounding implementation of universal health care.
So with the BBB, or One Big Beautiful Bill Act, passed this summer by Donald Trump and the Republican Party, we saw a gutting of the Medicaid program. And so what does that mean for people that are on Medicaid? And this particularly is in the form of work requirements. They put in a requirement that individuals need to be working at least 20 hours a week to qualify for Medicaid. And so this will kick off millions of people. I don't recall the number of people off the top of my head, but nationwide, there'll be a huge gutting of the Medicaid program. And this is important for even my own clinic, an FQHC that is mostly founded on these kind of services and does not turn people away because of Medicaid, Medicare, or uninsurance. And so are we going to stop providing this care? No. But are we going to be less funded and less financially sound? Yes. And so this goes up the chain. We've seen hospitals already begin to close as the hospitals that float on this Medicaid money, particularly in rural areas that have a higher level of Medicaid population in their area. We are going to see people, mortality increase. We know that these are completely preventable with access to good primary preventative emergency services that are were previously funded. What I will also add is that these work requirements are silly. One, they are punishing a group of the population that probably is already working. We know that 93%, when surveyed, were already doing some type of labor or just really should qualify when you think about it. So I'll list what those populations are doing, that 93%. They are older, meaning that they're retired and really are great, not working any longer. They are caring for a loved one. They are in school, or so that means college, or they are already working but do not qualify for, or that they're disabled. And so what a lot of these punishments will be is not on a person that is sitting at home doing nothing. The other thing about the Medicaid cuts and work requirements is that they are unnecessarily restrictive and produce a huge barrier between people and their care. And what I mean by that is, in order to validate these, they need to send out a lot of surveying to your employer or to tax agent, how you're getting your wages, to keep doing that every month. And so in states that did do this, like Arkansas, like Georgia, we saw a huge decrease in utilization, but we did not see an improvement in costs, because those costs were just dumped into administrative work. So again, it comes back to the question of, do you want your money to be spent on care, or do you want it to be spent on administrative costs?
I do want to talk about a few things. First, you can do 80 hours a month. It's a monthly check, and you can work, volunteer, or have an internship. So there's some flexibility there. I think we're going to see a huge increase in volunteering during that time frame, because it's a lot easier to volunteer than to get a job. And so that's a lower barrier to entry for a lot of folks. I know at the Washington level, our healthcare authority, so much of their effort in this upcoming calendar year is going to be frantically getting ready to implement this, because even the timeline that the big beautiful bill gave for this is like a year and a half to get a fully functioning hours reporting system out to the Medicaid community, which is not a community that often has a reliable internet access. It also punishes people who work outside of, work untraditional jobs because their reporting gets a lot more challenging. The group that's already being attacked by ICE agents outside Home Depots, because those folks might be working 60, 70 hours a week, but who's going to vouch for them? So we are really hurting that community. One thing I really like to bring up is Kaiser Family Foundation does yearly fact sheets for Medicaid state by state. And for Washington's this year, 70% of Medicaid adults were working, including 41% working full time. For this reason, Washington State, and actually one of our coalition members, is putting forth a bill to tax companies that have a large proportion of workers taking advantage of Medicaid instead of actually providing health insurance for their employees.
Whoa.
Yeah. Yeah. Here in Washington, it's Amazon. But really, 70% are already working, and our 30% that are not working, a huge percentage of those have some sort of disability or some barrier to entry to the workforce. When you start cutting Medicaid, who feels this the most? It's children. Children are disproportionately affected by cuts to Medicaid. Even if they don't lose coverage themselves, it's their parents, it's their grandparents, it's their loved ones, and all of that. I've told stories to my Congress people about students I've had, because I used to be a high school teacher, who would have to miss school for weeks at a time to take care of their parents after they had some sort of health emergency, because there wasn't anybody else in their lives who could take care of them. And so we see this health impact, the second and third and fourth order effects just destroy children, who again are a disproportionate number of Medicaid recipients are those children. And for this reason, something that came up earlier was the impact on rural areas, but children's hospitals get absolutely destroyed by Medicaid cuts. Already, children's hospitals, if you're on private insurance, you're paying like 5 times what Medicaid pays for those procedures at children's hospitals, at least here in Washington state. And it's just insane to say that you're not already paying for the people who don't have insurance or who are disadvantaged under our current system. I think these work requirements are such a nightmare. I hate that our HCA is going to waste the entire year, and instead of like trying to help people get better access, they're going to be like debugging and figuring out this last minute system to make sure that they can get 80 hours a month from all these, hundreds of thousands of Medicaid recipients here in our state. It's just such a waste of time.
And so these costs will absolutely fall out into the private market. So you and your employer, you're trying to get a raise this year. Well, they can't give it to you because expenses were up in terms of your healthcare that they need to provide. And instead of, they have to choose between the, 3,000, 4,000, 5,000 increase in insurance this year and giving you, a raise, and they just can't choose both. And like you said, these costs absolutely do pour out into the private market. By law, EMTALA, which is the Emergency Medical Act, so that if you aren't insured, the emergency room must care for you. These people still show up, but they show up much later. They show up much sicker. And what we're going to see is exactly that, and that the costs will just be shifted, if not worse, for the population that is insured. So instead of preventing a problem, we'll be addressing it surgically and on the back end. What you reminded me of was that in the clinic setting, what we'll see is people missing appointments because my Medicaid lapsed and I couldn't see the specialist. And me as a provider, a primary care provider, I absolutely needed you to see that pulmonologist for your asthma because I can't provide that care. Or I need you to go to the pharmacy to collect your medication. Well, my Medicaid lapsed, and so I can't pick up my inhaler, or I couldn't go to my chemotherapy appointment and get my infusion because my Medicaid lapsed. Therefore, my cancer advanced, and now, and it took months, if not, weeks, if not months, to get it reinstated. These are the kind of things that we're going to see from the fallout of the Medicaid work requirements. This whole rigmarole around stupid administrative nonsense.
Yeah, and our poor Medicaid people, they already have to worry about their employer scheduling them for too many hours because then they might make too much to file off of Medicaid. But now they're going to be afraid also on the low end of getting scheduled for too few hours that they no longer qualify for Medicaid. It's just, yeah.
And you made me think that it adds a risk to providers that are seeing Medicaid patients. Oh, well, their Medicaid wasn't, instated at that time. I guess we can't see them. So now those are lost work hours for doctors as well. So am I going to be incentivized to take on more Medicaid patients in the future? Absolutely not. They're not a stable payer group anymore. So it's so tricky. This is awful for everybody involved.
What is Wiser? Very simply, Wiser creates a new program for 6 states. It is actually a pretty even group of red and blue states. It's an attack on our Medicare system because Medicare Advantage was the first attack, and that introduced pre-authorizations to Medicare because Medicare Advantage was through private insurance, and they can do pre-authorizations. And now the next attack on Medicare is to introduce those pre-authorizations that occur within Advantage to normal, traditional Medicare. Right now, Wiser only applies to 14 of the more common procedures. The really insidious part of this is that they want the pre-authorizations to be carried out by AI, but the way these are incentivized to the companies that they're contracting out to is that any savings realized through denials is some percentage of that's going to be passed on to the company. So I can create an AI that works for that. You just say no. The incentive structure for this is horrendous. And even in pilot phase, it's going to kill a ton of people. Like, this is just a death sentence for so many elderly folks. I don't know what else to say about it. It's horrible. And okay, there is one thing I can say that's promising on this, which is that both in the House and the Senate, We have Washington representatives and senators. Patty Murray is doing the Senate one, and I forget who is in the House. Probably Jayapal Sabal. They're supporting a bill that, like, very, very short bill. Get rid of WISE. That's like the entire line of the bill. I think it's like a 2-line bill. And so that is being introduced this year in the legislature. There's been quite a lot of resistance. As you probably know, in the advocacy space, it's a pretty old space. There's a lot of retired folks, 65 plus folks, and particularly within our coalition in Washington State, the groups that are retirement folks heavy are very fired up about this and have been calling Patty Murray's office and our other representatives and senators and just badgering them about this. So people are very, very angry about this.
Well, good. They should be. I'm going to take one step back and just remind us of what is the problem with this whole situation. It's prior authorizations. And where are those prior authorizations and where were they utilized the most? It was in, they're used in Medicaid, but they're used in Medicare Advantage. And there are some prior authorizations in traditional Medicare, run by the government, accepted by 95% of doctors across the country. But those are much more restricted and they're much more fair and even. In Medicare Advantage, Medicare Advantage is run by private insurers. These prior authorizations are largely used to limit access to care. And so this increases profitability. Like we said, the systems that deny these procedures, medications, imaging, they get to keep this money. What we see is that when people do appeal these decisions, they 80% of the time, roughly, get their procedure approved. So that means that 80% of the time, these companies were wrongfully denying people care. But what we do know also is that only 10 to 20% of people ever apply. So in summary, this is a stupid idea. We shouldn't have prior authorizations that are just out of connection with what is actually needed. If a doctor is prescribing you a procedure, imaging, or a medication, we need to trust doctors. We need to trust the healthcare system that these are necessary care. And it's not to say we shouldn't have audits, but it's to say that we should not put private insurers in a situation where they're incentivized to deny care. And so what we're seeing with this, the WISER program, to bring it home, the WISER program is moving this not just from the Medicare Advantage population, but where private insurers are bound to make money. They're trying to limit the care of traditional Medicare, a system that was previously protected. So if we're keeping these on equal grounds, the Medicare Advantage, is much worse and inferior in terms of the care that it can provide, partially because of restricted networks, but partially because of the prior authorizations that people know and hate. So if you have the money and you can't afford to pay for it, everyone should be on traditional Medicare, and a lot of people know that and figure that out and get right onto it immediately. But what these do is they lower the value of the care that people can receive through traditional Medicare and put it on a more equal playing foot, potentially in time. This is just a pilot, but the fear is that this will spread so that it'll be in all states in a standard across Medicare, traditional Medicare, and then people will have no good options. Medicare is the one last vestige of protected care for people that are over 65 only. And what we believe, is that this protected care should be offered to everyone, because we know that mortality falls when people get onto Medicare immediately. We know that we have one of the best healthcare systems for individuals that are 65 and over. I like to say that we have one of the best healthcare systems in the world. We just don't provide access to everyone. Yep. And the Medicare population and the VA are great examples of that. The VA actually outpaces and outcompetes the Medicare population. But this WISER program will do harm to patients, but it will also put more money in the pockets of insurers offering Medicare Advantage programs as well, because they'll have a more attractive plan relative to the other option that is now a degraded traditional Medicare plan.
There is one more current event. I don't know if you saw on December 18th, Health and Human Services put out a letter saying that any hospital that provides gender-affirming care to minors will no longer be eligible to receive any federal money, which is one of the most draconian policies I have ever seen. I've never seen we'll shut off all of your Medicare and Medicaid money for anything if you do this one thing we don't like.
The only other thing I can think of was the integration of Black folks in Southern hospitals in the 1970s after the implementation of Medicaid and Medicare. This hits right along the topic, or along the lines for people that really are against this type of care in using the CMS and the federal government to implement this from a payer standpoint. Previously it was used for good to, desegregate these hospitals in the South. Now it's used for allowing children to access gender-affirming care. That will impact me. It will impact most providers, if not every provider that is working with Medicare or Medicaid, which is most providers. I don't know if does it only affect hospitals or does it also affect clinics?
I don't have the words in front of me right now.
It's okay.
I imagine they're going to expand it to clinics if it's not already in the first letter pretty quickly. My fear is what is gender affirming care? Is just providing a counselor to somebody who has gender dysphoria? Is that gender affirming care? Is that too much? Have you jumped the shark? I feel like this is going to force providers, clinics like yours and hospitals and all the others to be like, oh no, I'm not touching any of that. I can't do that, or I'm going to lose half of my funding for my entire clinic or hospital or whatever. And so I'm terrified by this. It is really, really scary just how general the language is and how it could be applied.
And why is this important? Not beyond someone's ability to express themselves the way they see fit as a personal freedom. This is an attack on people's mental health care, is what it comes down to. We know that people that are experiencing, clinical diagnosis of gender dysphoria, if not met with compassion, love, and care, they are at a high risk of suicide. And by ostracizing and isolating these folks, we know that this puts them at a huge risk that is just completely unnecessary. Where if we offered this care and had a world that was more accepting of how they express themselves, we could prevent some of the fallout from actions from the CMS. Yeah,
I mean, it's a pretty dark time for CMS and Health and Human Services and all that.
I mean, yeah, apparently Tylenol causes autism now. So I had to tell a patient the other day, please take Tylenol and not ibuprofen. Ibuprofen can close the vessel in your heart that allows your baby to shunt around the lungs prior to delivery. And then at delivery, that vessel closes and you push blood back into the heart and the circulatory system goes on. But the ibuprofen would cause that to shut early and potentially harm the baby, obviously. So it's and they've done great studies that, the American College of Obstetricians and Gynecologists put out a report in 2010 saying that Tylenol is absolutely safe. And they reviewed, let's say, 50,000 cases, I think it was. So it's just silly. The other one that I saw recently to note on was that apparently nurse practitioners, PAs, and nurses are no longer healthcare professionals, meaning that they don't qualify for the type of loans that are usually allowed to these groups. And so what does that mean? It means that they can't get as big of loans. They're capped at $20,000 for each year of nursing school. That's not going to do anything. That's not enough money. So where do they need to get that money? Instead of from federal loans, they're going to have to go to the private market. We already have a nursing shortage crisis in this country, and we know nurses are burnt out in general after COVID, and we see cycling of nurses as pay is not kept up with the demand of care We have the boomer population that's aging, and we're also closing the doors to nursing care from other countries in terms of immigration and visas to H-1B visas people that would come and work for the elderly population historically. And so there's gonna be a huge care disparity in this country, and the cost of care is likely to rise too as demand soars.
Yeah, all I can think of is just fewer low-income people are going to be able to go into nursing, and that's not good. We need people.
These are good jobs.
Yeah, they're good jobs. It's going to drive out people of color from those being nurses, PAs, doctors, whatever. Yeah. And so people aren't going to have doctors, nurses, whatever that look like them, that know their community. There's nothing good about it. Just to give a quick overview on whole Washington and what we're doing, we're a single-payer universal healthcare proponent organization. We're a 501c4 political nonprofit that pushes for political change to implement universal healthcare. And our big omnibus bill that would encompass all of the parts of universal healthcare that we see as valuable, that align with the UN standards and other organizations' ideas of this, are SB 5233 and HB 1445 in this legislative session. We have been introducing the bill since 2017. Last year was actually the first year we had it in both chambers, so a bicameral introduction. And we're really hopeful for January 12th of this year when our legislative session starts, and we can improve on those numbers and get support for our other bills, including the Universal Healthcare Commission deadlines and deliverables, and our Medicaid deprivatization bills, which are really the two we're pushing for below our big bill. The problem is our healthcare chairs receive a lot of money from the insurance industry. And so they have a lot of incentive to keep things the way they are. Not only that, our Senate healthcare chair was a hospital administrator before getting into this job. And that is the one side of our healthcare industry that feels like we're doing a great job right now, because, it pads their pocketbooks to keep it the way it is. As far as why single payer makes sense globally, we're just wasting 30% of the money we spend on healthcare at a conservative estimate on the entire insurance apparatus. And not only that, but on the amount of market consolidation we've allowed in the hospital space to continue to leech profits out of people and to push people away from care. We spend 50% more than any other country, even the second highest country we spend 50% more than, which is Switzerland, which has actually universal private healthcare. It's very interesting. Not the model we should be going for. And we spend 2-3x what comparable, even European countries with high standards of living spend. And it's really comes down to our entire private model. We're not saving money by doing the private healthcare model. Everyone is paying more money because we're doing it.
Absolutely. What we are looking at is a system that, instead of having multiple payers across many different complex forms of retrieving that payment and between the patient, the provider, going to a single payer really simplifies that idea down to, I provided care, I get one simple payment, and I know where that payment comes from. By removing that complexity, like you said, by removing the profit motives, and we can take that money and redistribute it to cover everybody. We're never going to get down to a point where costs are exactly the same because they've already inflated so much. But what we can do is remove those other things like inflation in terms of medication, administrative costs, and profit motive. Yeah, I think you already said mostly everything that I would say. Yeah.
If you want to hear about more from either of us, you can check out Whole Washington on like any social media platform. We're on everything. I post regularly to YouTube, Instagram, and Facebook with video content. And Paul, where would they find you?
I'm with PNHP, and we are currently working on universal healthcare for all at the national level, and single payer docs on Instagram.